Imagine a patient sitting in your exam room. Her main complaint is, well, vague, just progressive fatigue. But then she casually mentions a strange new habit.
Oh, right.
Yeah, she tells you she just can't stop crunching through massive cups of solid ice like every single day.
Such a classic presentation.
It really is.
Yeah.
And as a second-year med student getting ready to make that massive leap onto the clinical wards, your brain should immediately start flashing a massive warning sign.
Yeah,
Iron.
exactly. That symptom is pagophagia, and it's a huge clinical clue. You're transitioning right now from the theoretical world of M1 and M2 biochemistry lectures to the very real stakes of your M3 clerkships.
Right. And our mission today is to do a deep dive into the clinical guidelines and a real-world case file to help you bridge that gap. We're going to walk you through the diagnosis and management of iron deficiency anemia, or IDA, using a recent patient of ours. Let's just call her Joan.
Sounds good.
But before we even look at Joan's vitals, let's establish the golden rule of hematology. This is something you absolutely must carry with you onto the wards. Anemia is a symptom.
Yes. Say it again for the people in the back.
Right. It is a flashing check engine light. It is not a final diagnosis.
Yeah.
In resource-abundant settings, adult iron deficiency is a giant red flag for blood loss until proven otherwise. You don't just, refill the oil. You have to find the leak.
So true. So let's meet Joan. She's a 28-year-old bank executive. She presented with progressive fatigue, severely decreased energy levels, and exertional shortness of breath that had been building over several months.
And of course, she reported that intense compulsion to chew ice.
Right, the pagophagia.
Which is wildly specific to iron deficiency. I mean, when you hear it, you have to hunt for the source of the deficit. So we dug into her medical history. Joan reports menorrhagia. Her menstrual bleeding lasts 7 to 8 days per cycle.
But the days aren't even the most important part there.
I know, exactly. Here's the crucial clinical pearl for taking a history. She's changing her sanitary pads every 1 to 2 hours.
Yeah, and normal menses usually require pad changes at intervals of 3 hours or more. Changing every 1 to 2 hours is a huge red flag for an abnormally high volume of menstrual blood loss.
Because every milliliter of lost blood takes about 0.5 milligrams of iron out of the body with it, right?
Exactly. That math adds up incredibly fast.
And then she also told us she manages her severe dysmenorrhea by taking over-the-counter ibuprofen around the clock during her cycle.
Oh, man. Which introduces a secondary, covert risk factor. Chronic NSAI use induces gastrointestinal enteropathy.
Right, because of the HUX1 enzymes.
Yeah, we're talking about the inhibition of KOX1, which decreases those protective prostaglandins in the gastric mucosa. That loss of mucosal defense leads to microerosions and occult bleeding.
So it's blood loss you can't even see.
Right. It's just steadily draining her system from the inside out.
I always pictured Joan's iron status as a disastrous checking account. Like she's taking in pennies through her daily diet, but she's spending massive dollars every month through her heavy menses.
That's a great way to think about it.
And those NSAIDs act like a hidden recurring subscription fee that's just draining her account from the background.
Yeah, and her physical exam painted a really clear picture of that bankruptcy. She had mild tachycardia. Her heart was racing to compensate for the decreased oxygen carrying capacity.
Makes sense.
We saw noticeable pallor in her skin and conjunctiva, but, the peripheral tissue signs were really the most telling part.
Oh, for sure. She had angular cheilitis, right? Those painful erythema and fissures right at the corners of her mouth.
Yeah, and atrophic glossitis, where her tongue was entirely smooth and pale from losing its papillae.
Didn't she have early koilonachia too?
She did. The flattening and spooning of her fingernails, those mucosal and epithelial abnormalities show us that iron's role extends far beyond just hemoglobin.
Right, because iron is a necessary cofactor for cellular enzymes like cytochromes and ribonucleotide reductase.
Exactly. High turnover cells in the oral mucosa and nail beds rely heavily on ribonucleotide reductase for DNA synthesis and cellular replication.
So when tissue iron is depleted, those rapidly dividing epithelial cells simply can't replicate properly.
Right, leading to the atrophy and fissuring we saw in Joan.
So her checking account is clearly overdrawn, and her peripheral tissues are paying the price. But to fix the bankruptcy, we have to look at how her body handles the deposits. Let's trace the actual molecular journey of that iron to see where the baseline math fails.
Okay, so the average American diet contains about 10 to 15 milligrams of elemental iron. But the human body maintains a remarkably tight, closed system.
Meaning We don't absorb all of that?
Not even close. We typically absorb only 1 to 2 milligrams of that daily intake.
Which perfectly offsets the 1 to 2 milligrams we lose every day through, cellular desquamation in the GI tract and minor losses in sweat.
Exactly. It's a delicate balance that gets completely disrupted by her hemorrhagic losses. And when she tries to replace it through diet, she hits a bioavailability wall.
Right, because not all iron is created equal. Heme iron from animal proteins is highly bioavailable. About 30% of it gets absorbed intact.
Right, via the hem carrier protein 1, or HCP1, at the apical membrane.
But non-ham iron from plant sources or fortified cereals mostly exists in a ferric state Fe3+S.
And F3 plus is essentially a physiological brick.
A brick, I love that.
It is. It's poorly soluble in the higher pH environments of the intestine. So to get inside the enterocyte, that F3 plus has to be chemically reduced to the ferrous state, Fe2 plus, say.
And this happens at the intestinal brush border, right? Via enzymes like duodenal cytochrome, DCYTB.
Spot on. Only after it's reduced to F2 plus can it actually pass through divalent metal transporter 1, or DMT1.
So DMT1 is the active doorway, pulling FT plus from the gut lumen into the enterocyte.
Yes. And once inside, the iron faces a sorting mechanism. It can be sequestered into a protein cage called ferritin for safe storage.
Or if the body desperately needs it, it gets exported into the bloodstream through the basolateral transporter called ferroportin.
Right. But as soon as it exits ferroportin, the enzyme hephaestin oxidizes it back to the F3 plus state.
Why does it need to go back to F3 plus a plus?
Because it has to be in the ferric state to bind to transferrin. That's the glycoprotein shuttle that transports iron safely through circulation to the bone marrow for hemoglobin synthesis.
Okay, but wait. If Joan's tissues are literally starving, why doesn't her gut just open the floodgates and absorb all 15 milligrams from her diet to catch up? Like, why is she still so deficient?
Well, the liver certainly tries to help by suppressing a hormone called hepcidin,
Hexidin.
the master regulator.
Exactly. Hepcidin is the master regulator of iron homeostasis. When it's circulating, it binds to ferroportin, internalizes it, and degrades it.
Oh, so it traps iron inside the enterocyte.
Yep, where it's eventually lost through normal cell sloughing. But in a state of absolute iron deficiency like Joan's, hepcidin levels absolutely plummet.
So that means ferroportin and DMT1 are maximally upregulated?
Yes,
So the floodgates are technically open.
they are, but, and here's the catch, the human gut simply lacks the physiological density of transporters to absorb enough dietary iron to outpace chronic hemorrhagic loss.
Oh, wow. So she just doesn't have enough doors. Exactly. She might pull 3 or 4 milligrams a day instead of 1 or 2, but she's losing far more than that through her severe menorrhagia and the NSAI enteropathy.
The bottleneck is the absolute physical limit of the gut's mucosal absorption machinery.
Precisely.
Okay, so her physiological math is fundamentally broken. Now we need to prove it definitively on paper to rule out other causes, like, anemia of chronic inflammation. Let's look at her CBC.
Good call.
Joan's hemoglobin was 7.8 grams per deciliter, which is well below the normal 12 to 15 for women.
And her mean corpuscular volume, the MCV, dropped to 68 femtoliters, indicating severe microcytosis.
Super small cells.
Very small. And her MCHC was 28%, showing hypochromia.
Which makes sense chemically, right? Because the bone marrow's rate-limiting step for red blood cell maturation is hemoglobin synthesis.
Yes. When iron is scarce, hemoglobin production just stalls. The cell keeps dividing while it waits for enough hemoglobin to reach a critical concentration.
Resulting in mature red blood cells that are much smaller and paler than normal.
Right. And you can see this directly on her peripheral blood smear. Those small, pale red blood cells lack their normal central pallor density.
And didn't she have those occasional pencil-shaped cells, too?
Yes, which are a classic morphological hallmark of a marrow struggling without enough raw materials.
But looking at her CBC, there's a glaring paradox here that students need to catch. Her marrow is failing to produce red cells, but her platelets are elevated at 480,000. Why is a struggling marrow overproducing platelets?
That thrombocytosis is a reactive finding, and honestly, it throws off a lot of med students on the wards.
I bet.
When the kidneys sense severe tissue hypoxia from the anemia, they pump out massive amounts of erythropoietin, or EPO, to stimulate red blood cell production.
Okay.
Well, EPO and thrombopoietin TPO share significant structural homology. They both utilize the JK2-STAT signaling pathway.
Oh. So the massive surge of EPO in her system is literally crossing over and binding to TPO receptors on megakaryocytes.
Exactly. It acts as a weak TPO agonist. The sheer volume of EPO cross-stimulates those megakaryocytes in the marrow, leading to a reactive overproduction of platelets.
That's fascinating. It's just a biological byproduct of the body's desperate attempt to build red cells.
Yep. So to nail down the specific etiology, we look at the diagnostic iron studies. Serum ferritin is the gold standard because it directly reflects total body iron stores,
And Joan's ferritin was 8 nanograms per milliliter.
which is incredibly low. A normal ferritin range is roughly 40 to 200. Any level below 15 to 30 nanograms per milliliter is highly specific and diagnostic for absolute iron deficiency.
So an 8 confirms her storage vaults are completely empty.
Right. Even though ferritin can act as an acute phase reactant and elevate during systemic inflammation, an 8 cuts through all the noise. It's absolute deficiency.
And her transport proteins reflect that empty vault perfectly. Her total iron binding capacity, or TIBC, is heavily elevated at 450 micrograms per deciliter.
Because the liver is synthesizing and releasing massive amounts of transferrin shuttles to catch any available iron.
Right, but her transferrin saturation, the TSAT, is critically low at 5%. She has a massive fleet of shuttles, but they are all running empty.
That high TIBC and low ferritin completely distinguish this from anemia of chronic inflammation.
Because in chronic inflammation, hepcidin would be high, right? Locking iron away inside macrophages.
Exactly. In that scenario, ferritin would be normal or elevated, and TIBC would be low because the liver downregulates transferrin production.
Perfect. So we have our definitive diagnosis. Absolute iron deficiency anemia secondary to menorrhagia and suspected NSAID enteropathy.
Time for treatment.
Right. Joan's hemoglobin is 7.8, which is critically low, but her vital signs are stable and she's not hemodynamically compromised.
So a red blood cell transfusion is absolutely not required here. It carries risks of alloimmunization and volume overload.
Right. Avoid the transfusion if you can. The first-line therapy is oral iron, specifically ferrous sulfate providing 65 milligrams of elemental iron.
Because the ferrous Fe2+ state is what DMT1 can actually transport across the apical membrane.
But handing her a bottle of ferrous sulfate isn't enough. We have to leverage basic pharmacology to maximize that absorption. We use what I call the ascorbic acid advantage.
I like that. Joan is instructed to take her ferrous sulfate on an empty stomach alongside a large glass of orange juice or a potent vitamin C supplement.
Because ascorbic acid does some incredible chemical heavy lifting in the gut lumen. It acts as a powerful electron donor.
Right, chemically reducing any oxidized ferric F3+ iron back into the highly soluble ferrous F2+ state.
Furthermore, the vitamin C forms a stable, soluble iron ascorbate chelate complex.
Which acts like a chemical shield. As the chyme moves from the highly acidic stomach into the alkaline environment of the duodenum, the rising pH normally causes iron to precipitate out of solution.
But the ascorbate shield prevents that precipitation.
Exactly. It also protects the iron from dietary inhibitors. If she takes her iron pill with her morning coffee or tea, the tannins readily bind to the iron, creating an insoluble, unabsorbable complex.
The phytates in high-fiber cereals and calcium in milk do the exact same thing. So the ascorbic acid keeps the iron locked in a soluble state all the way to the DMT1 transporter.
But then we have to completely rethink the dosing schedule. Historically, we told patients to take iron 2 or 3 times a day to push as much through as possible.
Which we now know is a terrible idea. Joan is prescribed alternate day dosing. She takes her ferrous sulfate once every other day.
The mechanism behind this ties directly back to hepcidin.
I always explain this to my students using a nightclub analogy.
Oh, let's hear it.
Think of hepcidin as an aggressive bouncer at the door of the enterocyte. If you send a massive pharmacological dose of iron to the door, the bouncer gets overwhelmed.
And the liver senses the massive iron influx, panics, and spikes hepcidin production.
Exactly. That hepcidin circulates, binds to all the ferroportin on the basolateral membrane, and completely barricades the exit for the next 24 to 48 hours.
So if Joan takes another pill the very next day, her ferroportin transporters are still degraded.
Right. That new iron is blocked inside the enterocyte, entirely unabsorbed, and eventually just passes through the GI tract.
And it sits in the gut lumen, causing severe oxidative stress on the mucosa, which manifests as extreme GI irritation, nausea, and severe constipation.
It's miserable.
Yeah.
That mucosal toxicity is why up to 70% of patients simply quit taking their oral iron.
But by dosing every other day, you give the hepcidin spike time to clear.
The ferroportin transport is reset. You drastically improve the fractional absorption of the iron while severely cutting down on the unabsorbed iron that causes those miserable GI side effects.
It's a total paradigm shift for patient compliance, but, you also need a contingency plan.
Definitely. What if Joan's GI side effects are still intolerable? Or her ongoing menstrual blood loss demands a faster replenishment than the gut's maximal absorption rate can physically provide?
Then we escalate to IV iron. And as med students, you need to know that modern intravenous iron is exceptionally safe.
Yeah, you have to unlearn the historical fears of anaphylaxis. Those were driven by high molecular weight iron dextrans, where the large dextrin polymers triggered massive complement activation and severe allergic reactions.
The modern formulations are entirely different. We use options like ferric carboxymaltose or FCM,
Right. FCM utilizes a tight carbohydrate shell that binds the elemental iron securely.
which prevents the release of free iron into the blood, avoiding oxidative toxicity. Macrophages in the reticuloendothelial system take up the FCM complex and slowly release the iron directly to transferrin.
And because of that sable shell, FCM allows for a massive high-dose infusion. We're talking up to 1,000 milligrams in a single 15-minute sitting.
Which is perfect for Joan. As a busy bank executive, a single IV appointment repletes her entire total body iron deficit.
The alternative, iron sucrose, is also incredibly safe, but requires multiple hospital visits over several weeks to safely deliver the same total cumulative dose.
Okay, assuming Joan sticks with the oral ferrous sulfate and tolerates it well, she's going to ask you when she'll feel normal again.
Oh, they always ask that.
Yeah.
You have to understand the hematopoietic activation curve to set her expectations.
First, the pagophagia resolves almost magically, often within a few days.
Wait, really? That fast?
Yeah, this happens long before the blood counts change because it's a rapid recovery of tissue-level enzymes, not hemoglobin.
Oh, that makes sense. Then around day 7 to 10, the bone marrow fully wakes up. Now that it has the raw materials, it starts pushing out young red blood cells.
If you run a CBC, then you'll see a massive reticulocyte peak.
But her actual hemoglobin level won't measurably rise until week 2, and won't fully normalize to that 12 to 15 range until week 6 to 8.
Here's your clinical pearl. Rechecking a patient's hemoglobin or ferritin before week 4 is generally entirely useless unless you suspect active catastrophic bleeding.
You just have to let the marrow do its work.
Exactly. And this brings us to the most important clerkship takeaway. When her hemoglobin hits 12.3 at week 8, the anemia is resolved. But your treatment absolutely does not stop there.
No way. Her ferritin storage vaults in the marrow and liver are still completely empty. She must continue that alternate day oral iron for 3 to 6 entire months post-normalization to pack those tissue stores full again.
And even then, your job as a clinician isn't over. Treating the low hemoglobin is just treating the lab value.
Right. If you pump her full of oral or IV iron without addressing the heavy menses and the NSAID enteropathy, you aren't actually treating the disease. You're basically just dumping expensive fuel into like a car with a slashed gas line.
Joan requires a referral to gynecology for a comprehensive evaluation of her menorrhagia. They can intervene with a levonorgestrel intrauterine device or tranexamic acid to reduce the blood volume loss.
And she absolutely must be counseled to stop taking daily NSAIDs to let her gastric mucosa heal and stop the occult oozing.
You have to find and fix the leak. Treating the underlying etiology and managing the whole clinical picture is what separates a technician from an actual physician.
Well said. As you head on to the wards, keep Joan's case in the back of your mind. But before we wrap up today's deep dive, I want to leave you with one final provocative thought regarding the timeline of this disease.
Let's hear it.
Think back to Joan's labs. We saw how her ferritin dropped all the way to 8 before her hemoglobin finally crashed to 7.8. The physiological math dictates that severe iron deficiency exists long before overt anemia ever develops on a CBC.
That's a really good point.
So look around your clinic and ask yourself, how many healthy patients with chronic unexplained fatigue are walking around with fully depleted tissue iron, struggling with failing cellular enzymes, but being told they are perfectly fine simply because their hemoglobin hasn't dropped low enough to trigger an anemia flag? Start treating your patient's iron stores, not just the anemia.